So thank you all for coming. I'm talking on the Liberty multifocal. The key thing is the EDOF lenses are targeting the monofocal patients that we normally deal with, whilst the multifocal is always targeting presbyopia correction. And if you are going to use a multifocal, you have to nail it, otherwise it's a failure. If you don't nail the EDOFs, you still got good success. So we'll go through the criteria. So the problem is we hit 40 and the clock tells us we're presbyopic, and this is a different population of patients compared to the cataract volumes we get. So the multifocal component in my cataract refractive cohort is about 15%. Another 15% is EDOF, and the rest are monofocals, which work well. So as we can see, presbyopia is going through the roof, and presbyopia correcting IOLs is also increasing, as are EDOFs, because people want more than just distance correction. So what's on the market? I've used them all. I started using multifocals 20 years ago, very cautiously, got burnt, but revisited as new technologies came in. As you can see, the diffractive multifocal market there is quite open to many companies with lots of diffractive rings and lots of dysphotopsia. And there's also the refractive market, which has its pros and cons, which I'm not talking about today. But the key thing is with this Liberty lens, what is the difference? What's the standout between the other diffractive multifocals? And I'll go through that. So the patients have to be fully motivated, almost insistent they want to get out of glasses. You're not going to sell it as, I can get you out of glasses. You ask, do you want to get out of glasses, and how much do you want to get out of glasses? And once you go through the workup and you have gone through the standard exclusion criteria, you've eliminated a lot of people. So you're not going to put it in everyone. And when you have finally got that perfect eye and the demanding patient, you need to consent them. Now, interestingly, I'll give them two options. You can have this multifocal in the bag, or if you really are confused, and I'm confused, but you don't want to lose an opportunity, I'll put the multifocal out the bag. And we call that a dual lens system. I'll put the monofocal toric in the bag and a multifocal component without power outside the bag. And this is discussed in consenting. We warn them in 6 to 12 months of adaptation. There will be halos, there will be glare. You have to adjust. You find your sweet spot at intermediate and near. So if we look at the lens, it's hydrophilic acrylic. There's a big range. It's the high Abbey number and comes in toric. And I'll look at some more details of this lens. It's only the central 3 millimeters that are involved in delivering near and intermediate vision. That makes another 3 millimeters of the lens a monofocal. The ads are 1.75 and 3.5, generating 1.35 and 2.7 diopters of ad. As you can see, it's a diffractive apodized lens with a big central cone in the middle, and as you get towards the 3 millimeter zone, the apodization is smaller. But there's a new technology called EPS, elevated phase shift, which is a form of constructive interference which generates the intermediate, which is demonstrated in the light blue on this graph. And this is a very useful distribution curve explaining what happens with the pupil. The larger the pupil, the better the distance vision as you're capturing more of that monofocal component. The smaller the pupil, the better the intermediate and near, which goes with meiosis when you're reading. So it's an ideal platform that works for distance, intermediate and near. And it's that elevated phase shift, which is the second generation of this lens So it's EPS2 that's added profoundly to the intermediate zone. And you can see the ray tracing's acutely focused at the 1.75 diopter, and I can tell you now it works. EPS1, we struggled in the intermediate. It was more bifocal behavior, but now I can comfortably say this is a trifocal behavior. So I had a look at 60 eyes and 32 patients across the board. We did all the visual acuities, refractions, spherical equivalents, etc. And looking at the data was uncorrected and corrected, showing that 6.9 is almost guaranteed. N5 to N6 is almost guaranteed and intermediate. And the N5 and 6 at near was also spot on. And we looked at the refractive outcomes. So this is the critical step. If you miss on the spherical equivalent, you're behind the 8 ball. So you have to have a way to adjust, whether it's going to be a laser adjustment a year or year and a half later, or whether you're going to do an add-on type piggyback lens to combat the sphere and the sill. So that's the most important outcome, is that we have the ability to preoperatively predict that we will get the sphere and sill right, and the patients are forgiving patients, not OCD angry people. We should have happy patients. So post-op spherical equivalence within 0.5 of a diopter, 94%. Residual sill, 0.5 to 1. But even that's a lot. If you ask them, and this is the strangest thing I ever got from our patients, is, okay, how are you coping? No glasses. All of them. Those 60 eyes, no glasses. Well, that's impressive. I'm grateful. And then you ask on halo, glare, nitro, which I guarantee them, you are going to get halo glare. So few people are complaining. And this is different to the AT Lisa, the Panoptics, all the other multifocals that I've used in the past. They just say, whoa, those dysphotopsias are ridiculous. With this lens, it's so much reduced. So if you look at the ray trace, so on the left, you got the tight focus of the green lines. And if you look at the AT Lisa Panoptics Fine Vision, there's a much greater dispersion. Why? The number of rings. And maybe the plastic. Although the Lisa is the same plastic. And you look at a cross-sectional dispersion, which one's dispersing much less? It's the Liberty. And when you ask these people, well, what are the dysphotopsias? And I don't believe them. They say, oh no, 52% said there are no dysphotopsias. That's quite impressive. But I still don't believe them. I'm sure they got dysphotopsias. And they're just trying to be nice. So that's all I'm saying on the multifocal.